So it's very exciting to hear from leaders of innovations, and we're looking forward to hearing through this robust discussion we're anticipating that we're going to be having just exactly what that secret sauce is that would let these programs be more proliferating throughout the country. I thought, though, in terms of talking about palliative care principles, I'd get us started while people go up to the mics to talk about the issue of care planning. One of the things we know about palliative care and our principles of palliative care is that we look for impeccable assessment and care planning. And Dr. Loughnane mentioned the individual care plan as being necessary, and Dr. Lee was mentioning his comprehensive care plan. If we could quickly go through and hear how care planning and assessment, and then how you're monitoring it, and what role advanced care planning has in that in each of your programs, I think would be a good start.
Thanks, Judy. So the way we start with our patients is they have, it really starts from before we see the patient. We have an intake in person with the patient's family or caregiver or some decision maker of them, find out all of their kind of major issues and why they want to be in the house call program. And then on the doctor's first visit, they go through a pretty extensive medical, functional, and social assessment, which is in the electronic health record. And that kind of forms the framework for the care plan. And then the NP and social workers follow up with that over multiple visits, kind of building a living document within the electronic health record that's constantly changed and adjusted depending on the stage of illness. So it's really much a flexible, living kind of document over time in the electronic health record, but I have to say it's not a structured care plan itself. It's kind of working off of their active medical and social problems, implementing, changes, and then seeing if that worked. Advanced care planning specifically is in that document for both power of attorney and their goals of care, which the team has to document as we go along.
Thank you.
Ours is a work in progress that's quite similar. It's a sort of a step more formalized than what Eric described, with the additional sort of nimble ability to allow our patients, if they've got 5 minutes of time that they want to participate, we can just keep moving the ball forward and let them determine the pace. More or less within the first 4 weeks, they've experienced an encounter with a physician, nurse practitioner, and a social worker, plus or minus our spiritual health folks. We've got a 9-point sort of goals-driven care plan that we're using and improving on a going forward basis.
We're slightly different because we're a federal state program, so we have mandated annual care assessments and also other tools to see what the needs are. But so our challenge is, how do you not let them be static documents? So our training really goes around revisiting individualized care plans at point of intersection. So I think that's an important element that we've learned over the years. It's not a once-a-year care assessment for their medical and their long-term service supports. It's as needed that moves with the patient according to what their status are. And I do want to say that in my wish list, which I didn't put up there, is a real recognition that social determinants is the real next step in how we fund healthcare, because that is probably as important as anything else we mentioned today. So I think that needs to be the next annual assessment.
And for us, some of our health plans delegate us for complex case management. Others don't delegate, but they use a lot of the data that we have to be able to meet their NCQA sort of requirements. And so our care plan is going to be quite similar. We do, in terms of how we care plan, we do leverage a bit of data, and that as we've looked at, as we've done diligence through a lot of different health plans, we get data sets of all the claims for a lot of these plans. So we've been able to look through a lot of data and be able to have our healthcare econ department have what they call a data-driven acuity that takes into account many different factors. And so they give a predictive score, and then that helps us to prioritize patient outreach and gives us we have A, B, C, and D sort of stratification that gives it gives a suggested one, and then we do that intake, sort of the intake call. Then we do the in-person, where you can see the ADLs, IDLs, the sort of support and other things they have at home, and then that comes together to be able to, all of that comes into the care plan and then helps us with sort of risk stratification on, how do we best allocate the resources in terms of the patients?
Now, so that we can hear a good discussion from our audience, and why don't we start over here with Peggy?
Thank you. I'm Peggy McGuire from Cambia Health Solutions, and I want to thank all of you for your presentations and for the work that you're doing. I have questions about, and I'll start with Dr. Lee. My question is on both the provider side and the consumer side of the equation. How does your service change the consumer experience? Meaning, oftentimes there's fragmentation and there's no quarterback, and I'm curious about whether you're an extra layer or whether you're helping to create a more seamless experience for consumers. And then you hinted at, that's my first question. And my second question is on the physician side of the equation. How does the model impact the what we had been calling the quadruple bottom line, but the physician experience of care?
So in terms of our services, and again, it's in addition to the existing in addition to the existing sort of network, and so I think that we assume that we have to do all these sorts of things, because you can never be guaranteed that that maybe they don't make it back to the physician's office, maybe they don't communicate back to the PCP or their specialist, the sort of care plan. So we try to be very proactive in terms of calling and outreaching to the PCP network. And so for a lot of the larger groups, we'll try to set up JOC meetings where we meet on a initially monthly, then maybe quarterly basis to be able to talk about these sorts of any sort of communication issues. So that way it's less fragmented. And so I think there's a lot of the assumption that let's just overdo it and make sure that the communications are happening and that the care plans are being communicated, and that the observations are getting back to the providers. So I think the focus is on probably over communicating, and if they say, okay, we got that, we know that they're getting that, then we can always back off a little bit. But I think the assumption going in is always let's assume that it doesn't happen. Let's make sure that we push whatever we can to the network, and then we can always back off, as opposed to it doesn't happen and then there's a breakdown in communication somewhere.
And then, sorry, on the physician side, curious about how you think about the physician quality of life going out to see the various patients.
For our teams?
Yes.
Yeah, and it's not an easy job. I mean, we're asking them to have this sort of ownership and be available 24/7. So it is challenging, and I think we certainly are looking at ways to improve the windshield time, and whether leveraging technology for televisits. We do telepsychiatry because it is very scarce across many of the markets. But I think we do have. And also it's a fairly lonely job because you're out in the field by yourself. And so we do make for a once a week in-person meeting so that they still feel that sort of sense of team, that they can, in which case at those sorts of meetings, we actually got rights from Mattel or Hasbro to use Mr. Potato Head's likelihood. And so we actually have Mr. Potato Head as our Joe and Josephine, and that's tying it back to our patients. And so you always have to tie it back to the mission and the patients, because it is a tough job, but if they can really see the mission and the impact that they're having on the patients, that's going to be, I think that'll help to keep them motivated.
So I admire that. I think it's wonderful. I don't think it's sustainable. I think that's why we've always really focused on utilizing resources that are always available. And we really did have the same decision. Do we send me out at 2 o'clock in the morning, or do we send out paramedics who may have availability? So I totally admire, and I wish the whole world was like that. And I want Landmark. But I think that's a key question for all of us, is how do you take these ideas that are powerful and work in 45,000 for Landmark, 25,000 for us, and really get them So they're sustainable, have workforce, so they work for the vast majority of the United States. And I think we all, it's really interesting too, hospitalists who said, this is really broken. Our solution wasn't to fix the hospital, it was to fix the non-hospital. So I think that's a great question.
Thank you.
Thank you.
We actually are using piloting paramedicine also because, there are just frankly certain areas of New York City or other areas that you just, or like if you ever go to Chicago or something like that, you wouldn't want to send someone in at 2 o'clock in the morning. So, leveraging paramedicine or people that are used to going out there. We're looking
Thank
at
you.
that
So
also.
more leveraging. What?
And just a brief reminder that telehealth technology is bulletproof.
Yes.
Thank you.
Thank you for that.
Wow.
On this side of the room.
Hi, very interesting presentations. I'm Jane Tilley with the Administration for Community Living, and I'm very interested in, you all are dealing with complex patients, but many of them are going to have cognitive disability, be it from dementia, traumatic brain injury, I could keep going. Can you talk a little bit about how you serve that group of persons' unique needs, find out that they have the disability cognition, and then what happens, how you involve family, and then maybe, this is a lot, maybe pick one of these things. And then I particularly worry about the people that live alone with cognitive disabilities.
So, I think one of the first lessons when I joined CCA is the most important person is the personal care attendants. And through dual eligible plans and some other structures, there is funding to hire personal care attendants. And I think that is the real leverage point, because when I go into one of my patients' homes who has dementia or has intellectual disability or something like that, that personal care attendant, and usually they have 3 or 4 and not a whole cadre, they might cover 80 to 90 hours a week, is the partner. And I think that's an important aspect. So when we talk about social determinants of health, that always adds into my mind is being there. And if it is a family member, allowing the family member to sleep through the night while there's a personal care attendant there to help out. So I think we have to fund an environment of care and not episodes of care.
Anyone else for cognitive impairment?
Yeah. So Dr. Dennis, our Chief Behavioral Health Officer, helped us put together a behavioral health risk assessment tool, a screening tool. So it screens for, depression, PHQ-9, PHQ-2, geriatric depression scale, also screens for cognitive impairment, and also for substance use disorder. So I think identification is really that first sort of step, because people you may not know it on first glance that they have impairment. So I think doing the screening, and then I agree. I think that partnering with the caregivers or the family members or personal care attendants, the more education and support that you can give them, and even giving them a care plan that these are the things that we need you to be able to check on a regular basis, and if it falls out of these parameters, please give us a call anytime so that we can come and investigate. So letting them know that they're not alone, that because as a caregiver, it's a very challenging job, and burnout is very high, especially for patients that may have cognitive impairment. So providing them whatever support that we can, or having our social workers trying to find extra resources that are available. Maybe they're dually eligible and don't know it, helping them with the applications so they can get extra support.
Thank you.
Thank you. Over on this side of the room?
Yes. John Gardner. I'm retired from the National Center for Health Statistics, and I'm primarily now a science ethicist. One of the things that concern me most at the National Center for Health Statistics is the problem of access to care. And certainly the things you're describing very, very nicely today help us to deal with the problem of inadequate access to care, partially, but of course that doesn't solve 100% of the problem. And some of the discrepancies are ethnicity, other cultural issues, some are socioeconomic, some are rural, urban, and so forth. And I'm wondering to what extent do the types of programs that you're dealing with now help us to deal with the access to care problem, and to what extent is that problem just beyond anything your models can deal with?
Great question. So I would say that mobile care to the home can be done in every socioeconomic group, every ethnicity in every neighborhood in the United States. I actually think this mobile approach cuts the Gordian knot of access for this high-risk population, because we have folks going out all over DC, and in fact it's welcomed in every neighborhood of DC, and you can do it in rural and suburban areas as well. So I actually think creating these teams with adequate funding can really cut through most of the access issues for this subgroup of patients.
And as it relates to my particular access problem, remote and rural environments, imagine if you have less of an acute workforce deficiency, if you've got healthcare providers and practitioners living exactly where they want to, maybe in populated centers, providing care to people exactly anywhere, that also really narrows the gap in terms of being able to provide access, again, with the necessary capital and funding to support network development.
I'll add, the One Care program in Massachusetts was designed to do exactly that. Take people who did not access care or when they accessed it in emergency rooms. Two main points there. One is we use community health workers, so we've changed the workforce and said this isn't about doctors and NPs, this is first about just finding folks and creating that. And so community health workers and other entities go out and find people, and our unreachables have dropped substantially down towards, much less than they were before, and it just was the absolute ability to do that, which you can't do for fee-for-service. So if you're in fee-for-service in an office, you can't go out and see someone. If you have capitated premium or some other structure, you can hire someone to go do that very effectively. So I think, again, it's one of those where the funding will allow an open system for people to be creative in their communities about how to draw people in. And I think those programs in the United States that have done a good job at that, it's about peer-to-peer community health workers and others, and not the medical system.
Now, one interesting thing in terms of access that I found in a previous life was that, we rolled out a similar sort of model in inner city Detroit, which is a very challenging sort of neighborhood. And, there's, scarcity of providers who are willing to be in that sort of, in that area providing the services. When you bring the care to patients in those communities, yes, you have to have common sense. Sometimes you have to have security and whatnot. But over time, you're helping take care of their moms, their dads, their aunts and uncles. And interesting thing that you see happen is that after a while, they say, hey, these are good people. They're, don't. They tell others, don't mess with them, don't bother them. That you become a bit of the community, and so people who would normally not have access to a lot of healthcare or would have to travel a good distance to find adequate healthcare, you're able to bring that service to them where they're at, and then you become an accepted part of the community.
Thank you. This side of the room.
Hi, Marian Grant from the Coalition to Transform Advanced Care. Wonderful presentations, very exciting. Please scale up immediately. Just a couple of questions for Dr. Lee. One is on the slide where you talked about the different kinds of care that's provided. So there's the complexity, there's the behavioral health, there's the palliative. Is it the same team doing all of those components? And then I have a second question, which is, you also talked about the performance on the MA star ratings. And a number of us are having conversations about, CMS has opened the door for perhaps excluding the advanced illness population from certain metrics. And some of the metrics I would have chosen to exclude them from were on your list. So intensive control of blood pressure, a hemoglobin A1C, a BMI assessments. Can you talk a little bit about, those are the measures, but do you think that that's something uniquely we should be focused on for this population?
So in terms of the first question, we train everyone on the team. We have, even before they see a patient, we have a 3-week, what we call Landmark Academy of training, and then they go to one of our existing markets to do ride-alongs and more sort of evidence-based medicine sort of training. So there's a lot of upfront training so that people, everyone has a general sort of understanding, or at least consciousness of end of life, of behavioral health, of social determinants, so that I think they all we try to elevate their awareness. That being said, we do have psych NPs or psychiatrists, and so for the more serious patients, I think the general team will see the typical patient, if there are more challenging or more complex patients, then they'll refer to maybe the social worker or the psychiatrist or psych NP or whatnot if it becomes a more complicated sort of case. And then also we train what we call like local subject matter experts in, let's say, end of life, so that you have one person that you'll dedicate extra training, you'll send to other sorts of to get enhanced training, so that they then can become a local train the trainer in the market and be able to see the most challenging patients. In terms of quality, I think we bring up the same sort of concerns that maybe for this older population, some of these measures may not be the best ones to be able to address. But what most of the health plans do is that they'll look, their quality and stars people will look, hey, where are we having the most challenges and struggles? And that's where they'll point us to whether or not, I think that we do say that maybe there are better measures that could be measured, or maybe they may not be as applicable for this population, but I think they pretty much go by, where are we lowest, and then which one would we like you to try to focus on?
So imagine where we could go, or where you could go if we got you the right measures. Right.
Let's do one over here, and then maybe give the panel a chance to have some last thoughts.
Thank you, Judy. I'm going to focus on policy. The Independence at Home demonstration, a narrow version of home-based primary care, there's a broader view of home-based primary care, was the most successful demonstration in its first year in the history of CMS demonstrations. And all of your work suggests this is, as Marian said, something that we need to scale up today. There are national efforts going on that the John A. Hartford Foundation, my foundation, is involved in to establish a qualified clinical data registry and some training, large-scale training, so that there will be more availability of home-based primary care around the country. But there are still so many policy issues that are as yet unresolved. Michael, I'm going to turn to you. One of those is that today, if we were to think about, using technology to remotely access, yes, you, Michael Fratkin, sorry. We can only do that in places that are considered rural or frontier. And it can be a rural area, but if it's not within a rural state or, a designated area, it can be as remote as can be, but we still can't provide that service. When we think about things like dementia, that person has the same access issues as though, it could be right next door, but they may not be able to get to primary care. So I'm just wondering from each of you, what are the top policy issues that you see needing to be addressed to move this forward?
Why don't we just go on? This was the question I was going to leave you with, so we're right on time for it. Why don't each of you answer Amy?
Thanks, Amy. Obviously there's specific legislation that we can talk about and a variety of kind of the demonstration projects. Independence at Home is only one. So I think one thing is we need to think at the Medicare and Medicaid level of how do we encourage the House and the Senate to pass things that incentivize this kind of care. So mobile care with telemedicine, kind of interdisciplinary teams that have the time to kind of really make a difference in patients and families' lives. I think shared savings models are actually a pretty decent way to do that. That could be done not just with home-based primary care, it could be done potentially with some of the other models that have been discussed up here. So it comes down, for me, Amy, to kind of a grassroots effort for us to identify legislation that is before the Congress or help introduce it, and then activate people in this room and people over the country to get House members and senators to co-sponsor those bills. Because I think their interest is in reducing costs and improving the experience of their voters, and there's legislation that can do that. And IH is only one of those, which we can try to push.
The opportunities for geography agnostic innovation are enormous. We're sitting here at the National Academy of Sciences in Washington, D.C., in a room of people that are predominantly part of large organizations. Out in the far, far wilderness of far northern California, there are opportunities for innovations that are made available by these technologies that are at all of our fingertips. And with your support, you may look beyond the population centers, and you may look beyond to where the pain points really are, at the leading edge, at the point of the sphere, in community-based practices. If we had a capitated, value-based economic foundation with uniform availability, then I think that these technologies can really be put to work to deliver the kind of care that everybody would want for themselves and everybody would want for those that they love. We can also use these technologies to solve some of the burnout problems, some of the workforce deficiency problems, by being nimble, by being clever, and by being inspired together in collaboration. So, my thoughts.
So I have two answers. The first is we need to change how we value primary care in the United States. We need to recreate Michael's dad, have that valued, paid well, and be not a vocation, which it is now, but a rational, reasonable job for someone to want to do. And then you make those providers have some upside and small downside to the care they deliver. They have to have some accountability. But if our world was 80 to 85% primary care providers, we're not here.
And I think I echo a lot of the same, is that, you know, if we can reform the payments and make it more value-based, where it's outcomes, because I think, you know, the trends will follow the incentives, and the more patients, I think MA, Medicare Advantage, is certainly moving. There's more traction of more patients in terms of the MA penetration. I think on the fee-for-service side, there's a lot of the opportunity. So I think as we can shift more and more into the value-based payments, I think, you know, I think the innovations and a lot of investors who will put in a lot of money to be able to fund a lot of that sort of innovation. So if you can change the payment reform, I think you'll get a lot of dollars towards innovation.
Thank you very much for that helpful advice. And so with this, we're going to go take our break and then continue the conversation outside at the break. Thanks, the panel.